Hello, good evening. Welcome our esteemed and respected seniors of the profession, our respected members, the seniors of the Pharmaceutical Society of Kenya, respected pharmaceutical technologists joining us today. Welcome so very much to today's webinar. We're going to begin at exactly 7:05 or closest to when we are. Karibuni sana katika wanaohudhuria katika somo letu la leo kuhusu jukumu la mwanafamasia kwa kuzuia mgando wa damu. Somo limedhaminiwa na shirika la BEA na litaongozwa naye daktari wa dawa Dr. Susan Mageto. Tutaanza pindi tunapofika watu 200 ama saa 1:05. Ile ambayo itakuja mbele ndio tutaanza hivyo. Asanteni. In the meantime, ladies and gentlemen, esteemed members of the Pharmaceutical Society of Kenya, kindly note down which ward you're joining us from. Which ward you're joining us from. Asanteni on the chat box. It's an election year. Probably you want to know your ward. Which ward are you joining us from? Asanteni sana. I can see Dr. Nilish Akbaral from Eldoret, Dr. Chege Riki from Karori Ward, Dennis Orango from Nyamira, Dr. Karanja from Kisii University, Dr. Emmanuel and I can see Rafael Kaberia from Maua and Evelyn Osano. Karibuni sana to today's meeting. Eldoret Philcrest Pharmaceutical Chemist, karibu sana. Dr. Etole. Thank you very much, Dr. Mutai Ngweri from Meru. I can see Abdinur from Garissa Township. Dr. Eva Washuka from Kirinyaga. Welcome so very much our esteemed attendees for today, esteemed colleagues, technologists, pharmacists, esteemed seniors of the profession, esteemed pharmacists of the respected seniors of the profession, esteemed professionals of the Pharmacist of Kenya. Dr. Ajay Patel is here with us. Karibu sana daktari. Welcome to today's meeting in partnership with BEA Pharmaceuticals. The role of the pharmacist in anticoagulation. It is the role of the pharmacist in anticoagulation. Karibuni sana. It's going to be led by none other than Dr. Susan. We begin at 7:05 or when we get to 200 attendees. We are almost at 200 attendees. Dr. Sharon Sumuko says you can't hear me. Anybody else who can't hear can put it up. Okay, I hear you. So let me work on my sound. How about now? Is it okay? Sharon Sumuko, can you hear me loud and clear? Wonderful, wonderful. Better. Dr. Dagane, the marketing director, Coast and Northeastern region. Karibu sana daktari. Karen Kiambi from Karen, karibu sana. Dr. Patel Pankaj from Nairobi, Dr. Ajay Patel from Dhika, karibu so very much to today's meeting. Dr. Katis Marubu Kemsa, karibu sana. Dr. Isaac Ngok from Kericho, from Cheson Pharmacy in Kericho Town, karibu sana. As I had promised, our esteemed attendees for today, thank you and welcome to today's meeting on the role of pharmacist in anticoagulation. The meeting is hosted in partnership with BEA Pharmaceuticals Kenya, and also it is hosted by, it's going to be taught by none other. The speaker for today is none other than Dr. Susan Mageto, who is a lecturer at Mount Kenya University and an anticoagulation pharmacist at TruPharmaCare at Pharmacist. Tena nitawakaribisha sana wahudhuria wetu wa somo letu la leo. Somo letu la leo ni kuhusu jukumu la siri la wanafamasia kwa kuzuia mgando wa damu. Somo letu la leo limedhaminiwa na shirika la madawa la Bayer na litaongozwa naye daktari wa dawa Dr. Susan Mageto. Nitaweza kuwapeleka moja kwa moja katika mawaidha ambayo tutaweza kuyatumia katika huu mkutano. A few ground rules and announcements. Thank you so very much for participating in this session. Participants are muted during the entire course of this session. Please ask questions via the Q&A tab at the bottom of your window. Questions shall be addressed by presenters on the Q&A tab. For PSK members, if not already done so, please subscribe on the PPP portal for the conference so that you can get your CPD points. CPD points will only be awarded to paid up members. For KPA members, the attendance list shall be official for awarding CPD points. A point to note is that this session is being recorded and will be made available on PSK's YouTube page. So without further much ado, this is the agenda for today. We welcome and opening remarks. After that, you're going to have the speaker of the day, Dr. Susan Mageto, who's going to take us through the role of pharmacist in anticoagulation. After that, you're going to have Velma Barasa from Bayer and the Q&A. Without further much ado, ladies and gentlemen, members of the various professional bodies, Kenya Pharmaceutical Association, Pharmaceutical Society of Kenya, senior respected members from the Pharmaceutical Society of Kenya, welcome to the meeting. And without further much ado, allow me to welcome none other than Dr. Susan Mageto to join us and take us through today's meeting. Dr. Susan Mageto, are you there with us?
Yes, I am.
Let me share my
screen. Thank you.
Yes, you can share your screen, Dr.
Okay, I hope everyone can be able to see my slides.
Yes, you can see it, Dr.
Thank you. So my name is Dr. Susan Mageto. I am a clinical pharmacist. I work at MKU and I also do anticoagulation management at TruPharmaCare at Pharmacist. So today I'm going to take you about to take you through the role of a pharmacist in anticoagulation management. And this is going to be my table of contents. One, I'm going to start with the introduction. Number two, I'm going to give a brief overview of the problem. And then we are going to look at some of the anticoagulants. And then you're going to be able to see why pharmacists are more suitable to be able to actually do what offer anticoagulation management services. And then you're going to look at the role of the pharmacist in offering anticoagulation management services. And then in terms of selection of anticoagulants. And then we're going to look at in the monitoring. Also, we're going to look at what are some of the advantages of pharmacy-led anticoagulation clinics. We're going to look at some of the basic requirements that you might need if after this session you will decide to set up one. And then we can also check I can also take questions in the final slide. Okay, so without further much ado, let's dive in. So what is VTE or venous thromboembolism? Because this is what we'll use majorly, what we'll use anticoagulants to treat most of the time. So it's in layman's language or in very simple terms, VTE are just blood clots in the veins. So there are two forms of VTE, and there's a deep vein thrombosis, that is DVT. And here you have blood clots forming in a deep vein where maybe in the lower leg, thighs, pelvis, or arm. And then there's also pulmonary embolism. And this is a complication of DVT, whereby the clot now breaks away from the either leg, thigh, or arm, and is able to find itself into the lungs. So it's a clot in the lungs. So what is the pathophysiology and risk factors of VTE? So I know all of you remember the virtuous triad. So these three conditions are usually met before someone gets a clot. So there's endothelial damage, there has to be an hypocoagulable state, and there also has to be stasis. So some of the risk factors for endothelial damage will include smoking, hypertension, surgery, catheter lines or PICC lines, and then trauma. And then hypercoagulability, one of the risk factors might be hereditary and the others might be acquired. So you might be having hereditary issues such as factor V Leiden, prothrombin, protein C and S deficiency. You might also have some acquired or some diseases that will actually cause you to be in a hypercoagulable state. So cancer is one of them. Chemotherapy is another one. Let's say pregnancy, obesity, hormone replacement therapy, etc. Then stasis, so immobility. Maybe, for instance, you have patients who have strokes and they have to stay, they're not moving, they're basically mobile, they're not ambulating. There's also polycythemia, and this actually might end up again causing endothelial injury, and you end up having again a clot. So that is the brief of pathophysiology and the risk factors associated with the development of VTEs. Okay, so what are the clinical manifestations? So for VTE, these are some of the clinical manifestations that you get. So there's asymmetric leg or calf swelling. It's one of the clinical manifestations. Pain or erythema. You might also have dilated superficial veins, and you need to note that these are non-varicose veins. Then for PE, you might have dyspnea, syncope, palpitations, pleuritic chest pain, hemoptysis, and cough. So these are some of the clinical manifestations or some of the patient history that a doctor will be able to get from the patient, and they'll be able to know that this patient, they would suspect that this patient has either VT, a DVT or a PE. Excuse me. So what is the problem that we have in terms of anticoagulation? So when you look at papers done in the country, I sampled quite a number, and there's poor quality of anticoagulation therapy. Basically, patients are not spending enough time in the therapeutic range when it comes to anticoagulation. So there's poor quality of anticoagulation therapy. Another thing is that there's poor patient education on anticoagulants. Studies have also been done in the country, and you could be able to see that on patients who are on anticoagulant therapy, they do not understand what they are on, how long they're supposed to take these drugs for, and sometimes why they are taking these drugs. Yeah. The other thing that is a problem is the scanty data on anticoagulation outcomes. We all know that anticoagulants are not your normal drugs. They have very serious side effects. They can cause bleeding in patients, and therefore, when you give out these drugs, we expect to be able to know what are the outcomes for this patient in terms of, are they getting better? Are they bleeding? Are they dying from these anticoagulants? And because you're not following them up very well, there's very little data in the country on anticoagulation outcomes. Okay, so let's look at antithrombotic therapy, or some of the drugs that you'll encounter when you're going to be dealing with anticoagulation. So there's Wafering, very common in our setup. There are also direct oral anticoagulants. There are also thrombin inhibitors. We have heparins. So you'll have unfractionated heparin and low molecular weight heparin, which usually called clexane in our setup. Then you can have thrombolytic drugs such as urokinase or alteplase. You might also have some patients being put on antiplatelet therapy. But for the purposes of this lecture, we'll focus more on warfarin, heparins and direct oral anticoagulants and thrombin inhibitors, because those are the major anticoagulants. So unfractionated heparin or heparin, what they do is it activates antithrombin, which in turn leads to inactivation of thrombin, factor 2A and factor 9A. Yeah, just remember your coagulation cascade and you'll be able to note that where these drugs actually act. Yeah. So what are the advantages? So there's rapid onset and offset of action. Then there's ability to monitor activity of unfractionated heparin. You can monitor it through activated prothrombin time, thromboplastin time, sorry, and then antifactor 10A. Then you can also, there's also a lack of substantial renal elimination when it comes to unfractionated heparin. So you can be able to use unfractionated heparin when it comes to renal failure. And then extensive clinical experience. Heparin has been around for quite some time. So our clinicians and even our clinical pharmacists have been able to use it for quite a long time, and they're able to know, they are familiar with how to handle it. Yeah. Then there's an available antidote that is readily available, that is protamine sulfate. So in case of anything, when you have bleeding experiences with this patient, you know what to do, and the antidote is readily available. So what is the limitations? Number one, it has a short half-life, so you need to keep, most of the time, sometimes you give it as an infusion, or you'll have to give it several times in a day. Then there's no oral formulation. Then it can cause what you call heparin-induced thrombocytopenia, skin reactions, and even osteoporosis, especially if you use it for long. And then they have a higher bleeding risk, especially when you compare it to other anticoagulants, including low molecular weight heparins. What about warfarin? So warfarin, as I said, is very common in our setup, and it is a vitamin K antagonist. It interferes with vitamin K dependent clotting factors, that is 2. 2 is supposed to be 2, 7, 9, and 10, and protein C and S. Yeah. So what are the advantages of warfarin? What are the advantages? Number one, it is cheap and easily available, and there's a large body of clinical experience. Yeah, being one of those old drugs, again, there's a large body of clinical experience. Then there's significant experience with reversal of anticoagulant side effects. We can use vitamin K, we can use platelets, and then there's ability to increase the intensity of anticoagulation with appropriate monitoring when required. And this is one thing that makes warfarin very attractive, because you can be able to monitor and increase or decrease the dose depending on how this patient is doing with their INRs. Then what are the limitations? The higher rates of VT recurrence and bleeding complications. So studies that have been done will show that warfarin, the outcomes of warfarin, there's higher rates of recurrence and also bleeding complications. Then frequent monitoring with associated costs and burdens. So it's not cheap. The drug itself is cheap, but when you start factoring in the INR tests, and the time that these patients will keep spending coming to the hospital to actually do what? To actually get tested, and then wait for some time, and then they're given now their results, and now their maybe doses adjusted. So, and that is what happens in most of our hospitals, that the labs are the ones which are handling these tests. And so these patients will come, they'll have an INR done, an INR test done, and they'll spend like 2 or 3 hours waiting for the results. So a lot of time is spent doing that. Then warfarin interacts with so many things. Warfarin will interact with the drugs this patient is taking. Warfarin might also interact with foods, and this makes it very difficult for some patients. Yeah, and then it's contraindicated in pregnancy, though sometimes there's a small window where we are able to use warfarin in pregnancy, but it's usually contraindicated. So that's all about warfarin. So we're going to look at the DOACs, which are the direct oral anticoagulants. So here you'll have the two different classes, that is direct factor 10A inhibitors, such as rivaroxaban, apixaban, and edoxaban. Then you also have the direct thrombin inhibitors, such as dabigatran. And what are the advantages of DOACs? Number one, you will give the same daily dose. This is when you compare it to warfarin. Warfarin, today I might be giving this patient 5 milligrams. After a week, this patient, their INR is high. I have to give them 2, or their high INR is low, so I have to increase the dose to 7.5. And so there's a bit of, there's no consistency. But when it comes to DOACs, you give the same daily dose. If it's 20 milligrams, it's 20 milligrams. It's 15, 15. Then there's minimal to no lab monitoring, unless under special circumstances. Then there's few drug interactions, very few. And then there are no dietary interactions when it comes to DOACs. And you can treat an acute clot as outpatient with oral medication. Remember, when you're dealing with warfarin, most of the time you'll have to do what we call initiation. So this patient will come to the hospital, and sometimes we'll have either to do what, we'll have to give them Clexane to go home with, they inject themselves, or we will ask them to admit them so that we can be able to give them Clexane for at least 3 to 5 days as they're taking the warfarin, so that the warfarin can reach therapeutic levels and they're able to do what? To leave the hospital. But that is not the case when it comes to DOACs. So if a patient comes today and they have a clot, the only thing we do is we put them on either rivaroxaban on that day and we send them home on outpatient basis. So that is an advantage. And then there's lower risk of bleeding when compared to warfarin. So what are the limitations? Multiple dosing in a day. Warfarin, you take it only once a day. But this direct oral anticoagulant, sometimes you have to take them at least 2 times a day. Then they're more expensive, yeah, although there's some generics that have come into the market, and also even the innovator brands have actually reduced their prices. So, but it's more expensive relatively when you compare to warfarin. Then there's difficult to dose in patients with renal dysfunction. Yes, so these drugs, some of them you can be able to give them at certain creatinine clearance levels of these patients, and therefore in certain renal dysfunction, you might not be in a position to give patients these drugs. And then there's difficult reversal, especially in emergency situations. So the antidotes are not very accessible, okay? And it's very hard for you to do reversal, especially if this patient is in an emergency situation. Then monitoring is very difficult. Yeah, monitoring is very difficult because basically, if you look at APTT levels, PT levels, people sometimes use them, but they're not very predictable when it comes to DOACs. And the drug interactions, they have some drug interaction with cytochrome P450 enzymes such as 3F4 inhibitors and inducers. So those are some of the limitations. So when you're looking at a patient and you want to give them anticoagulants, there are some special considerations that you should be looking at. So some of them are if this patient is on a mechanical heart valve. So which anticoagulant should I give them? Which one should I not give them? Yeah. For instance, patients with mechanical heart valves are not given the DOACs. Most of these patients, you'll find them being given warfarin. So if this patient is pregnant or breastfeeding, again, which anticoagulant are we going to give them? We've already said that warfarin is contraindicated. So most of the time, we are able to give them what? Low molecular weight, heparin. Then there's extremes of body weight, obesity. For instance, when you're talking about, let's say, rivaroxaban, obesity is an issue. Or extremes of body weight generally. Then cancer is also another one. there are some studies that have started showing that some of the anticoagulants, especially some of the drugs, when you give them to patients with gastrointestinal cancers, these cancers that already have a predisposition to bleeding, such as gastrointestinal cancers, they are able to bleed more. Yeah. So you need to be able to weigh and consider which anticoagulant to give to which patient. Then chronic kidney or liver disease, again, when it comes to DOACs, this one you need to be very keen on. Also, when it comes to low molecular weight heparin, such as clexane, you need to be able to note that when it comes to kidney issues, you need to either reduce the dose or not give it at all. Then history of bleeding. So if this patient has history of bleeding, so you need to weigh vis-a-vis what is the potential for this patient to bleed and what is the potential for this patient to do what? To throw a clot. And then you're able to do what? To come to a consensus on which one to give and which one not to give. Okay. So when it comes to the role of pharmacists in anticoagulation, the most I have rushed through the others because I wanted to get to this place whereby we are discussing the actual role of a pharmacist in anticoagulation. When it comes to the pharmacist, there are three major roles you're playing when it comes to anticoagulation. One of them is selection. The second one is monitoring. And then the third one is now patient education. So let's look at anticoagulation. Selection, anticoagulant selection. So when most of the time you'll be in a position to be asking yourself, what am I going to choose for this patient? Is it warfarin? Is it a DOAC? What exactly am I choosing? Why will I give this patient warfarin and not a DOAC? Why will I give this patient a DOAC and not warfarin? So what are the instances where we prefer warfarin? Number one, significant liver disease or end-stage renal disease. So here, the best bet or the safest way to go to give would be to give warfarin. The other one is mechanical heart valves, whereby warfarin is preferred, and then atrial fibrillation, especially if this patient has moderate to severe mitral stenosis. Then, if this patient has concomitant therapy with interacting drugs, so maybe this patient is being given a DOAC with a drug that they cannot replace that is interacting with a DOAC. So in this case, you just have to give warfarin. Then, especially if this patient has poor adherence or missed doses, then you might give warfarin because you're able to track via the INR and see if this patient is actually adherent or not. Then, when are DOACs preferred? Generally, they're preferred in guidelines. In the guidelines, sorry, I did not put the above there, but they are generally preferred. You'll see in the subsequent slides in the instances where they're preferred, because what has happened is DOACs, you don't require much monitoring. One, so even if you have difficult patients who have issues with forgetting when to take their medication, who have issues with diet, because when it comes to warfarin, you need a very consistent diet. So you'll find doctors are slowly or steadily pushing most of the patients to DOACs because it gives them an easier time managing these patients. Then, if this patient has poor INR control despite adequate adherence, so you have a patient who is very adherent to their drugs, is very consistent with their diet, but at the end of the day, their INR control is still inadequate. Then difficulty obtaining regular INR checks, which is also a big problem for most patients. I, for instance, have a patient who is in Mandera, and getting INR checks is very expensive on that end. They're doing, I think INR checks is around 3,000. So if you tell this patient, I want you to do an INR check after 2 weeks, it's like you're telling them to spend 6,000 every month for just doing INR checks. Yeah. So there's a difficulty. If you find such a patient, that patient is best pushed towards DOACs unless they really must be on warfarin. Then drug interactions that can't be managed with warfarin, adjustments. Yeah. So there's some drug interactions. We said warfarin basically interacts with so many drugs, and if there are sometimes interactions that you find that this patient maybe will forever be on this other drug, and you cannot keep maybe reducing the dose or adjusting the dose according to that drug that this patient is being given. So the best way is to actually just push this patient to direct oral anticoagulant. So when you're talking about direct oral anticoagulants, as we said, there are very many. Yeah, there are also quite a number. And because they're quite a number, you need to ask yourself, which DOAC will I give this patient? Okay, so which DOAC am I giving this patient? And why am I giving this patient this DOAC and not this other DOAC? So as we say, as I was saying on the other side, in the previous slide, that most of the reasons why people will choose DOACs will be basically because maybe a patient, a clinician has better clinical experience with that drug, or insurance, they're able to get their patients paid for that drug. And then the cost also, maybe the cost is relatively cheaper, maybe to put a patient on rivaroxaban rather than putting them on apixaban. So there's no, let's say, set way of choosing which DOAC. But there are things that you can be able to help your clinicians and the place where you work on what considerations they should be able to look at before they choose one DOAC over the other. So number one, there's increased, you can check increased risk of bleeding. We have scores that I'm sure some of you have learned, such as the HAS-BLED score. So you're able to check and see what is the propensity of this patient to actually bleed. And so the bleeding risk, as we see, is higher when you're dealing with apixaban, apixaban, then edoxaban, then rivaroxaban, and it is lowest when you're dealing with dabigatran. So you're able to gauge your patient depending on the DOACs that are available to you. Then renal impairment, you need to check the percentage of renal elimination. And in the next slide, I'm going to show you renal dose adjustments when you have certain patients. But generally, when it comes to percentage in renal elimination, you have apixaban being the major one that is excreted, has a larger percentage of excretion, renal elimination, then Xarelto, then edoxaban, and then Pradaxa. And then drug interactions. So you need to check which one has major drug interactions and be able to choose, depending on what your patient is on, which drug is better suited for them. Also, once daily dosing, sometimes you'll have a patient who will tell you, I can't be able to actually take a drug for more than, I can only take a drug once, yeah? Because maybe they have many drugs they're taking, they don't want to increase their pill burden more. So you have to be able to consider that. So you can give them on once daily dosing of Xarelto, or you can give them edoxaban. Then if they're taking GAD medications or need to use a medication organizer, and in this case, you're able to, you have to avoid drugs such as Pradaxa. Yeah, so you have to avoid dabigatran, because dabigatran usually will require acidic environment for absorption and needs to be kept in its original container. So you're talking about these patients where I know in our pharmacies we are selling these pill containers, yeah. So which are labeled Monday, Tuesday, Thursday, like that. And this patient is on Pradaxa, and you're taking Pradaxa from the tin and putting it there, and it's not supposed to be given. And again, or this patient is actually on GAD medications, which are anti-reflux medications, and then this patient, this drug will require an acidic environment so that it can be absorbed. Okay, then obesity. If they have a BMI of greater than 40, then you need to maybe avoid Pradaxa, because the available evidence suggests that there's a possible increased risk of harm when you give such to a patient who is overweight or obese. So what is the standard dosing when you're talking about DOACs? In our setup, most of the time you'll find that we'll use rivaroxaban and quite dabigatran once in a while. Yeah. So when it comes to AFib or atrial fibrillation, we'll do 20 milligrams once daily when it comes to rivaroxaban. And if we are treating VTE treatment, we are treating venous thromboembolism, that is either PE or DVT, then it's 50 milligrams twice daily for 21 days, then 20 milligrams daily. And then if you're doing prophylaxis, then you can give 10 milligrams once daily. Okay, so there's, as I said, these drugs, they have an effect when you have renal disease or renal impairment, and therefore you need to do what's called renal dosing for these drugs. So if it's atrial fibrillation and you're dealing with rivaroxaban, you need to check the creatinine clearance. If it's 15 to 50, then you can give 15 milligrams once daily. If it's less than 15, you need to avoid the use. If you're dealing with VTE and you're treating it, if it's less than 30, then avoid use. If it's VTE prevention and it's less than 30, also avoid use. So apart from selection, what you are dealing with, what that was selection, you'll be able to help patient, your doctors tell them this patient will be better suited for this because they have certain characters that require them to be given this over this. So there'll be a lot of switching between agents. You'll start a patient on warfarin, and then they realize they can't handle it and you need to switch it back to, or you need to switch it to rivaroxaban. Or you'll have a patient on rivaroxaban, and for some reason, you need to switch it back to warfarin, okay? And you need to be able to advise your clinicians on how to go about this. So if it's warfarin and you want to switch it to rivaroxaban, you stop the warfarin and you start the Reltor when the INR is less than 3, okay? And if it's a Reltor you're giving, or what you call rivaroxaban, and you want to switch this patient over to warfarin, then you start warfarin, then overlap warfarin and DOAC, usually for a minimum of 2 days, or until the INR is therapeutic, and then you stop the Reltor, yeah, so that this patient can be able to continue with their warfarin. So that goes for all the other drugs I have given there. So how the other place that you're going to be able to make a lot of impact as an anticoagulation pharmacist is warfarin dosing, and this is where your main job will be. Because as much as we have a lot of newer drugs coming in, most of our patients are on warfarin. We live in Kenya or in a low-income country, and most of our patients will be on warfarin. So you need to be able to know how to initiate warfarin, how to be able to adjust their doses according to the INR. You need to be able to know how to handle these patients in when it comes to do what? When it comes to bleeding, if they bleed well on the drug, you need to be able to advise or do a lot of patient counseling for these patients initially before they start taking the medication. So before we even discuss the warfarin dosing. So once a patient comes to you and they're on warfarin, there's some things that you need to be able to make sure that they understand. You need to talk to them about their diet, yeah? Tell them about their diet, tell them you need it to be consistent, tell them the type of drugs that most of the time we actually ask our patients that in even over-the-counter medication, even if you're going to buy a medication, text us, call us, ask us, are you, I'm going to take this medication. Is it compatible with the drug that I'm taking? Or if they're going to be seeing another doctor, then they should be able to tell this doctor, I am on Wafering. And because I'm on Wafering, if you're giving me these drugs, are they okay with what? With Wafering. So you need to be able to empower this patient with a lot of information so they can be able to do what? To start their journey with Wafering. You need to be able to tell them about the pointers that they should be looking out for in terms of if they're going to be bleeding. Are they going to, if they're going to have a nosebleed, what should they do? If they're brushing their teeth and they see blood, what should they do? Yeah, such things. So this is a guide for warfarin dosing. This is from up to date. There are so many guides for warfarin dosing. So on day 1 and 2, when initially you just give the patient 5 milligrams, and of course they'll be taking another anticoagulant such as Clexane or heparin. Then on day 3, you start checking their INR. So now you start adjusting their doses according to their INR. So if they have 1.5, less than 1.5, you give them 10 milligrams. If they are 1.5 to 1.9, you give them 5. If the INR is 2 to 3, you give them 2.5 milligrams. If it's greater than 3, then you give them 0. And this is just a sample. This is based on a patient whose indication requires an INR, a therapeutic INR range of at least 2 to 3. Okay, so there are patients who will have an INR range of 2.5 to 3.5. Okay, and so on. So there are some who will have a higher INR range, a therapeutic INR range, and there are some who will have a lower therapeutic INR range. And warfarin, this is an example of how you can be able to do what? To initiate and be able to monitor this patient as you adjust the warfarin dose until they get to their therapeutic INR. So when it comes to the duration of anticoagulant therapy, again, this is something you can be able to give your input on, because this patient will come and you'll be able to say, this patient has higher risk of recurrence of VTE, and because they have higher risk of recurrence, then they should be on these drugs for more than 3 months. 3 months is too little for them. Or you can be able to say this patient has an existing long-term risk of thrombotic events, and because of that, I should be able to do what? To give this patient lifetime, maybe a warfarin or any anticoagulant that you'll be able to choose. So when you're looking at, let's say, VTEs, if it's the first event and it has a risk factor that is either reversible or time limited, then most of the time you'll give 3 months with INR range 2 to 3, or you can give treatment dose of factor 10A inhibitor. If it's unprovoked VTE, or it's a first or second event, then you can give 3 months with INR 2 to 3 or factor 10 inhibitor. Then you can also consider indefinitely to give this patient the medication, especially warfarin with an INR of 2 to 3, and you weigh recurrence versus bleeding risk. Or you can definitely move this patient to maybe maintenance dose of factor 10 inhibitor. Then there's some special situations where you be able to give indefinite anticoagulation. So if you have a first event with cancer, until it is resolved, this patient, the best way is to consider chronic low molecular weight heparin or 10A inhibitor, because if this patient is going to be having cancer for quite some time and they're also on anti-cancer agents, cancer is itself an hypercoagulable state. The agents that you're using to treat it can actually put this patient at a risk of cancer. So for as long as they're maybe on these drugs, you can be able to be on prophylaxis. Then antiphospholipid antibody syndrome, if this patient has that condition, then this one you give indefinite anticoagulation. Or if this patient has a compelling family history of those hereditary factors that we talked about, then this patient is eligible for indefinite anticoagulation. The other thing that we need to be able to do is vigorous prophylaxis in high-risk situations. So you're able to be able to categorize your patients on, are they high risk or low risk in terms of throwing clots, yeah? And if they're high risk or low risk, then if they're high risk, then what should we do? Then we should be vigorously prophylaxing them. So monitoring is one of the other things that you as a pharmacist should be able to do. So when it comes to the unfractionated heparin, most of the time you will do serial activated prothrombin type. And then when it comes to low molecular weight heparins, then you'll use anti-factor XA, okay, to be able to check the levels of these drugs. When it comes to Wafering, we've talked about it. Do your INRs and be able to adjust the doses accordingly. If you're talking about DOACs, as I said, DOACs, basically, you do not need to monitor them unless you have very special circumstances in these patients. Maybe these patients have taken an overdose of these drugs and you're scared about them, or maybe you need to be able to monitor them before they are able to go inside for a surgery, an emergency surgery, and you now start deciding to do what, to monitor them. But most of the time people will use PT or APTT, and sometimes anti-XA, and these are not recommended because they're unpredictable in assessing a DOAC activity. So basically, when it comes to DOACs, we'll just say there's some level of, let's say, you don't need to actually monitor them. So why a pharmacist-led anticoagulation clinic? So when if I were to give you some few minutes and you were to just go on Google right now and say pharmacist-led anticoagulation clinic, you'll find papers upon papers telling you that pharmacist-led anticoagulation clinics perform better than those led by other health cadres. So it's a fact that is out there that studies have shown that pharmacist-led anticoagulation clinics perform better than any other health cadre. And this might be attributed to the fact that we have extensive knowledge of Wafaring's pharmacokinetic and pharmacodynamic properties. And also with these new drugs such as DOACs and all others, we are able to know their pharmacology very well, and you're able to know where to apply it when it comes to clinical work. So that is one of the major reasons that we are actually the ones who perform it better than any other health cadre. So if you want to set up an anticoagulation clinic, number one, you need to establish need for service and get institutional backing. So if you're in an institution such as a hospital, especially if you're in level these referral hospitals, I believe that no referral hospital should be operating without an anticoagulation clinic, because you see a lot of patients on Wafering. So you have to find out how many patients are on Wafering and find out what the problem or the burden is and start getting institutional backing. You get institutional backing by making sure that the hospital sees the need for an anticoagulation clinic. Then you need to look at the financial considerations. What is the cost that will be incurred to set up the anticoagulation clinic, and what is the benefits that the hospital is going to reap when it comes to the anticoagulation clinic? You need to select a medical director. So especially if you're doing it as a private practice, then you don't need a medical director. But if you're doing it in a hospital setup, then you need to have what you call an anticoagulation champion. Yeah. So, and this usually will be a hematologist or a cardiologist who understands very well the need for anticoagulation services managed separately by a pharmacist. Then you need to clearly define your purpose, goals, scope of service, and also the target population of patients that you need to target with your services. You also need to determine staffing needs. Will you need a pharm tech? Will you need a nurse? What will you need? Then establish training and qualification requirements for staff. most of the time you will be able to get someone to train your staff on some of the nitty-gritties of anticoagulation. Then you need to establish roles and responsibilities of staff. You establish supervision, which will usually be with you who is the pharmacist-led anticoagulation service. So it's a pharmacist-led anticoagulation service. Most of the time will be the supervisor. Then you need written policies and procedures, quality control, and you need other considerations, clinic hours, health and safety, collaborative practice, etc., etc. So I was asked to talk about my experience, and one of the things that helped me so much was MTRH. MTRH, when I was trying to set up the clinic, they even gave me a point of care machine. Okay. So, and they are also usually very willing to give you all the materials that you need to start the anticoagulation clinic. So you need to be able to get out there and be able to find these things that you'll need. What are the written policies and procedures? What are the machines that you'll need? And what are the financial requirements that you will require? So finally, what are the advantages of an anticoagulation clinic? What are the advantages of an anticoagulation clinic? And in this case, a pharmacist-led anticoagulation clinic. So to the patient, most of the pharmacist-led anticoagulation clinic, we don't use the lab machines, which take 2 hours to give us results or 3 hours. So you'll use a point of care machine. So a finger stick INR, it's usually very less invasive. So patients are more receptive towards it, and it's instant. I prick your finger, it's just like a diabetes test, sugar test, yeah. Formalized patient education. You're able, as a pharmacist, you're able to talk to this patient. You're able to assess their needs in terms of education and be able to explain to them what their medication is all about, what they're suffering for, how they're supposed to take this medication, what they're supposed to avoid. So you do a lot more, especially when it comes to patient education. So there's improved adherence to medication, and this patient is able to decrease their chances of getting an adverse event from the anticoagulant. Then the patient handout decreases potential for dosing errors. You have to always give a patient a handout that shows specifically, today you're going to take 5 milligrams. So you usually have a weekly chart that has Monday, Tuesday, Wednesday, Thursday, Friday, Saturday, Sunday. So on Monday, this is the dose you're going to take. On Tuesday, this is the dose you're going to take, like that, like that. So they're able to just check and see, today I'm taking 5 milligrams. Okay, tomorrow I'm taking 7 milligrams, like that. Then clinic visits avoids patients' face-to-face contact with healthcare provider who can triage patients' healthcare concerns to appropriate provider, which results in decreased need for hospital services. So basically, you're preventing emergency visits, because this patient is able you're able to monitor this patient more through the anticoagulation clinic than through the normal clinic, that they have to go through a lot of let's say procedures before they get to the clinic, to the anticoagulation bit. But now you've cut that short. So when they come, they're coming to the anticoagulation clinic to sort out their issues with their anticoagulants. Then anticoagulation clinic staff can coordinate other healthcare providers to provide optimal patient care. So sometimes you find that these clinics might fall on days that other clinics also fall on, and you can be able to, as a pharmacist, and these days we are talking about MTM, you can be able to sort all the patients' medical needs, any drug needs at a go. Then improved clinical outcomes and patient satisfaction. So you'll find that patients who have ever been to an anticoagulation clinic, you will not convince them to go back to going to the hospital and going through other channels before they get to the anticoagulation clinic. They'll always want the procedure that they have been used to when it comes to the anticoagulation clinic. So they're very satisfied, and usually they have improved clinical outcomes. So the institution is also able to get some advantages, because the staff that are specialized in anticoagulation management will also often end up with additional education and training. So you have some set of highly qualified staff in certain areas, and then staff focused on anticoagulation management, and therefore there's improved communication and patient follow-up when it comes to this. Patients, then staff follow approved protocols resulting in consistent dosing and monitoring. Yeah, so you'll have a protocol for your dosing of this medication, and so these patients will always they will not you won't have a provider differences when it comes to anticoagulation management, because everyone is following a certain protocol. Then you can be able to track effectiveness of treatment and modify as need, resulting in improved results and thus better clinical outcomes. So the thing is, when especially, let's look at a case in point where we're talking about warfarin. You're able to note if these patients, are they getting well? Are they getting recurrent VTEs after treatment? Are they bleeding? Or are they doing what? Are they dying because of anticoagulants? So most of the time, and that is why we don't have enough data when it comes to the outcomes, it's because we do not have anticoagulation clinics. No one is solely focused on these patients to be able to find out how are these patients faring on. You'll find a lot of papers on anticoagulation coming from MTRH, because they have a pool of data where they can pull out data and say, by the way, we are giving this drug and we've realized this drug is causing this, and this is the data to show it. But because some of us in the hospitals that we practice in, we don't have access to such data, because you're not able to have this large pool of patients who we are following up on to be able to get this data. It's also cost effective in terms that you're able to generate revenue for the institution. These services are not free. Patients will pay for them. There's also improved efficiency in the use of resources, doctor or registered nurse time, because so you can imagine, there are surgeries that are supposed to be done. Why do you need a cardiologist following up a patient on anticoagulation? Yeah, there are patients who need to have to be changed, to be checked up on by the registered nurse. And why do we need to waste, not really waste their time? Why do we can divert these resources and make better use of them in other areas than in anticoagulation. And pharmacists can also be now pharmacists can make better use of their time now, because you'll be able to run an anticoagulation clinic and you're able to spend a lot of time in the clinical area. So decreased overall healthcare costs, because now you're minimizing complication and maximizing effectiveness. So you're preventing, if patients are being treated very well on especially if, let's say, they have DVTs, you're making sure that these patients are receiving the correct care. We expect that there'll be a reduction in the number of PEs in that institution, and therefore we are decreasing the overall healthcare costs and you're maximizing effectiveness. So what is the future of anticoagulation? Private consultancies, which I think we're already there, or some of us, I know quite a few who have anticoagulation clinics that are running. So this is something that might increase in the future. There's telemedicine or digital medicine. As I said, for instance, I have a patient who's in Garissa. This patient, I can't keep telling them to come to Fortis after every 2 weeks. We have to find a way of coexisting. So you find a place where maybe they buy a point of care machine, or they're able to get their results from there, and then they're able to call you and you're able to advise them on the way forward with their medication. Then collaborations with medical consultants. We are looking forward to when we'll have maybe hemato-oncologists partnering up with pharmacists in their clinics. So all the patients who require anticoagulation monitoring, maybe from the cardiologist or the hemato-oncologist, are sent to the pharmacist who practices in that clinic, and that symbiotic relationship is able to thrive. So that marks the end of my presentation. I know it was quite a lot to grasp, but I hope I've covered the basics. So I want to welcome any of you if you have any questions. Thank you.
Thank you so very much, Dr. Thank you so very much. Just before we handle the questions and just before we go, allow me to give you a small break, probably a 10 minutes break for you to even breathe. And I can see the questions are coming in pretty much. So allow us to now be joined in by Velma. Velma, can you hear us?
Yes, I can hear you clearly.
Karibu sana, the chance is yours now to present, Velma.
All right. So thank you so much, Dr. Mageto, for the presentation. I think you've really outlined it very clearly, where you as the pharmacist are very important in this whole anticoagulation process. So perhaps if you just thought that you're good enough at the dispensing phase, then clearly there's much more that you can be able to do in the anticoagulation setup, and just to enhance proper patient care. So I'll just take you through a few slides, and thank you again to Bao and your team for allowing us to partner with you during this event. So let me know if you can see my screen.
Yes, I can see your screen and I can hear you loud and clear, Velma.
All right, thank you. So I'll just take you through a few slides, and I know that I has mentioned about different anticoagulants, and yes, there are different anticoagulants that are available, but from there we have Xarelto, the original rivaroxaban. And we'll say why choose Xarelto over the other anticoagulants. Of course, it's a case-to-case basis, as well highlighted by Dr. Susan, depending on the patient's profile, what are the underlying factors that they have, but there are those category of patients who can benefit from Xarelto. And so we want to, generally, when we look at it in terms of anticoagulation, we say that select a good drug and for the patient, help them to understand the why they need to be compliant on the treatment, and the duration of treatment and how to take it, so that as soon as possible they can go back to their day-to-day activities. Like for this lady who was enjoying her farming time together with the son or with other workers, if it's a career person, they can go back to their day-to-day activities in the office setup. If it's a medical, we want to give good medications so that patients can recover from their symptoms as quickly as possible, and they continue with their day-to-day activities when they are well managed on their drugs. So as I mentioned, that Xarelto is the original rivaroxaban, and from there we have aspirin cardio is the oldest pharmaceutical product that we have, which is over 120 years as we speak, and it is still available and well stocked in quite a number of the pharmacies countrywide. So Xarelto is the original product. There are several clinical trials that have been done and that are still ongoing, just to ensure that it can be used safely across different types of patient population, just to manage this whole anticoagulation processes that are necessary. And of course, there's a lot of research that is done, and these are some of the highlights that make it very different from the generics, which they just once the patent is over, they just reconstitute the active ingredients to create their drug, but they don't go through the extensive medical clinical trials. And so Xarelto has several indications. So we have the lowest dose is 2.5 milligram, given as a twice daily dosing for these patients with coronary artery disease and peripheral artery disease. Then it's also recommended for non-valvular atrial fibrillation patients with the whole intention of preventing episodes of stroke. And our biggest indication is the PE-DVT space, where now it cuts across the young to the older generation. And probably I'll just focus on a few segments of that particular indication. So as properly and clearly highlighted by Dr. Susan, rivaroxaban is an easy drug to use. Of course, it is oral. There's no need for anticoagulation monitoring, not unless you have those concerns as Dr. highlighted in her presentation. It's a single drug approach. For some of the patients, they may not necessarily require admission, and so you can just safely start them with Xarelto from day one of treatment, and always emphasize to them how they need to take it with drug, how to take the drug to ensure maximum benefit. So I'll just emphasize on that in subsequent slides. It's a very simple dosing. Mostly it's once a day besides the first phase of treatment for the DVTPE indications. Then in general, there are no dietary restrictions, unlike a patient who's on Wafering, and there are fewer drug and fewer drug-food interactions, unlike the VKA patients. And of course, as I earlier mentioned, shorter hospital stay. You can initiate the patient from day one, or if they need to be admitted, then they can benefit from a shorter hospital stay. That means you're reducing the treatment cost overall, and the patient can go back and recover from home. So one important highlight that backs up the statement that it can be used from day one of treatment, or when you're switching from enoxaparin to Xarelto, it's very easy. It's because of the fact that it has a very rapid onset of action. So with enoxaparin, it has the onset of action of about 0 to 2 hours, as highlighted with the blue line. But with rivaroxaban, it's about 2 to 4 hours. So you find that with both drugs, between 2 and 4 hours, you're already at your peak plasma concentration, and that is why we say that it can be used from the first phase of treatment. But other features about Xarelto is that when it comes to bioavailability, why I was saying that you have to emphasize to the patient how to take it. The 20 milligram and the 15 milligram, it's recommended to be taken with food so that you can increase the bioavailability to around 80 to 100%. At fasting state for these two strengths, it's only about 66%. So the patient may be compliantly taking it at 8 p.m. as an example. But if they're taking it at 8 p.m. or fasting stage and then they eat their dinner, you know, there are those guys who maybe because of work shift or something, they eat very late into the night, then there's still that big chance that the patient ends up exposing themselves to a risk of further clot formation, yet they are already on treatment. So patient counseling is very important, and it's well highlighted and emphasized at the pharmacy level. But if the patient is on the 2.5 milligram or the 10 milligram tablet, they can take it with or without food. The bioavailability is not affected. And this is just the unique pharmacokinetic and pharmacodynamic properties of rivaroxaban as a molecule. So the half-life for the young adults is 5 to 9 hours, and the elderly is 11 to 13 hours. It's an important point to factor in, especially if maybe the patient needs some surgical intervention or they are having a bleeding event. So just having this information then helps you to know how best to handle the patient. Of course, if it's an event of bleeding, you have different bleeding management strategies depending on the severity of the bleed. Then, as I mentioned earlier in the previous slide, it has a fast onset of action of 2 to 4 hours. And when it comes to the excretion, a third of it is usually excreted as an unchanged product. We do not recommend it for the patients who have severe renal impairment. So for those patients who have a creatinine clearance of 15 and below, they're better off on another anticoagulant. And so, otherwise, if you give this patient, you're just overworking the kidneys, and you just be pumping in the drug there, but it will not be metabolized. So for the DVTPE indication, as I said, the dosage is very simple. The first phase of treatment, we recommend the 15 milligram as a twice daily dosing. And here, as I said, they need to take it with food. Then from day 22 to about around 6 months, then they're supposed to take the 20 milligram as a once daily dosing. So should the patient still have the risk factors that predispose them to getting a recurrent event, then they need to be maintained on Xarelto still. So if they have low risk factors, then the physician may opt to reduce the dosing to 10 milligram. But if the risk factors are still high, then they need to be maintained on the 20 milligram. So the first phase of treatment, why it's the only phase of treatment that Xarelto is recommended as a twice daily dosing, is simply from the outcome of this meta-analysis of 15 VTE clinical trials that involved over 27,000 patients. And they were being checked every day. You're on treatment, but are you still at risk of getting an event, yet you're on treatment? I believe some of you have received such a report that the patient is already on treatment, then they end up getting an event. So there's always a question of what is happening behind the scenes. Is the patient taking the drug properly? Is it the right drug? Are they compliant to the dosing? Are they taking it with food or without food? Those are some of the things that the patient needs to be, questioned, so that you identify why there's a problem. But the outcome of this particular meta-analysis is that it showed that the first 3 weeks of treatment, almost 4 weeks of treatment, that's when any patient on any anticoagulant is at risk of getting a recurrence. And that's why for Xarelto, we say the first 21 days, give it as a BD dosing, then you can downscale to a once daily dosing of the 20 milligram. Remember to tell the patient to take it with food in order to increase the bioavailability. If it happens to be a non-valvular atrial fibrillation patient, because we do not recommend it for patients with valvular atrial fibrillation. So for this particular NVF patients, we recommend those who have normal renal function, let them take 20 milligram as a once daily dosing every day. But for the patients who have moderate renal impairment, they can take the 15 milligram as a once daily dosing. As I mentioned, for the patients who have coronary artery disease or peripheral artery disease, they need to be given it Xarelto 2.5 milligram together with aspirin. We have the bioaspirin cardio 100 milligram, just to protect these patients from the cardiovascular events. So remember, this is the only dose that is recommended you give together with aspirin, because it's the lowest dose. Otherwise, for the 10, 15, and 20 milligram, please do not give together with aspirin. Otherwise, you'll predispose the patient to risk of bleeding. So as I mentioned as I was beginning, as you're dispensing, as you're thinking about this anticoagulation, as you're thinking about servicing this prescription for the patient who needs an anticoagulant, or in that anticoagulant clinic, if you're trying to select what's the best option for my patient, just like Dr. Mageta's patient who's in northern Kenya, think about that grandmother, your grandmother, grandparent, the person who's there in the village. You want to save them the hassle of going to do the INR test. You want them to be on good medication so that they can do their day-to-day activities without so much stress. So some of the highlights that I'd like to mention have already been mentioned nicely by Dr. So I talk about switching. If it's a patient who's on a VKA and you're thinking about in terms of this patient is far away, INR testing is a challenge in itself, perhaps because of cost, perhaps because of compliance. Keeping that patient within the recommended therapeutic range is difficult. And I was told that when you change the brand of Wafering from one brand to another, you end up tipping the scale of the therapeutic range the patient is supposed to be on. So if you don't have that particular brand the patient has been initiated on, let them just go to the next pharmacy where they can get the brand they're used to. Otherwise, you may keep them off the recommended INR range. Yeah? So switching, as Dr. highlighted, just always remember that VKA has a very slow offset of action. So it takes a couple of days before the effect of Wafering clears from the system. So you have to keep checking the INR on a daily basis until the therapeutic, until they get to a range of about 2.5 and below, then you can start the Xarelto treatment. And the same applies also to the AF patient. Once the INR is below 3, then you can start Xarelto. For that patient who may be admitted and they're ready for, they're due for discharge, then it's simple to switch from the parenteral to the oral, because of the fact that rivaroxaban has a fast onset of action. So just those 2 hours before the time you give the injection, then that's the time you need to consider giving the Xarelto. Remember, even as they are admitted, they need to take it with food. So if it's a hospital setup where food is served very early, like for example, I think I've heard of some hospitals that serve food as early as 5 p.m. or 6 p.m. Then drugs are given at 8 p.m. or 9 p.m. If it's a patient on Xarelto, then at that time when you're giving the drug, they need to be given a small snack so that they can take it with food, to increase their bioavailability. For some of the patients who we don't recommend Xarelto treatment, it's for the patients who are below the age of 18. Locally, we don't have the pediatric formulation or the pediatric dose, because some of you may be already aware that in some markets we have a pediatric dose of Xarelto, but locally we don't have, so we don't recommend it for the patients under 18 years of age. Of course, I've mentioned that it's not recommended for patients who have a creatinine clearance of below 15. Then maybe something that is also important for you to know as a pharmacist, for the patients who are concomitantly taking systemic strong inhibitors of both the CYP3A4 and the PGP inhibitors, such as the azole antimicotics or the HIV protease inhibitors, these patients are better off on another anticoagulant because they'll compete on the same site of metabolism with the Xarelto, and then the patient doesn't get the benefit of the drug, of either the drug they're taking. So but if it's topical application for the azole antimicotics, that's different. This is now for the systemic treatment. So that's something that you need to focus on. Then just a small highlight: if a patient misses a dose and they want daily dosing regimen of either the 10, 15, or 20 milligram, they just need to take it as soon as they remember. Then they continue the next day as recommended or as preferred, if they prefer taking the drugs at night. But if they're on the first phase of treatment where you're given the 15 milligram as a BD dosing, it is highly recommended that they take both tablets once they remember. Then the next day they continue with once in the morning, the other tablet in the evening, so that on that particular day they have taken the 30 milligram. As I said, you want to reduce the incidence of recurrence while they are still on treatment. But if they are on the twice daily dosing of the 2.5 milligram, then they should not double up the dose. So let them just continue when they remember to take it once in the morning and once in the evening. So for those of you who don't know or are not familiar with Xarelto pack presentation, that's how it is: the 2.5, 10, 15, and 20 milligram. I believe by now most of you are aware that we reduced the price quite a while back. And just the whole rationale was just to ensure that more and more patients can be able to afford treatment. So for those patients who are already on Xarelto and they're coming for a refill, please just maintain them on Xarelto. For those with an open rivaroxaban prescription, then you can consider giving Xarelto as your drug of choice. And why do we say Xarelto? Remember still your parents, your family members who are far. You remember that working class person who needs to just have proper treatment and well-maintained anticoagulation. So if you have that in mind, what other thing are we offering as when it comes to patient care journey? We have a lot of resources, both print and digital material. We have a very brief dosing guide that quickly just highlights the indications and the dosing. It's a very small document. Then we have a more detailed document, an A5 size document that talks about, of course, the indications, the dosing, and the pointers that I've highlighted in the presentation. What do you do in the event of a missed dose, overdose? It has got the well score criteria, to just assess the bleeding risk. It has got the CHAD score. It has got how to manage bleeding. It has quite a lot of content. So I'm sure some of you have already interacted with some of these materials. But if you happen to meet any of us, our team, just request for material. Yeah? On the digital platform, you can go to thrombosisadvisor.com or Xarelto.com just to interact with the digital material that is there. Xarelto.com will give you purely the information on Xarelto, but thrombosisadvisor.com will give you much more information even regarding the other anticoagulants that we don't even have locally. Then additional resources that we have, as I said, to enhance the patient care journey, we have the patient alert card. On one side, it has got information about what they need to know about rivaroxaban, how they need to take it, when they need to contact a healthcare professional. And on the other side, they can fill in their personal details or the doctor's details in case of emergency. We have some wristbands, which can be worn by willing patients, especially those ones in the machinani, those elderly patients who may not be able to express themselves. To say Xarelto or rivaroxaban, it's a hard word to say, but the band is written on them. I am on an anticoagulant, just to identify them. Of course, patient counseling needs to be done before such things are given. Yeah. Then we also have patient information booklets on DVT, PE indication, and also on the AF indication. Simplified information to help the patient understand the why. And lastly, we never forget to emphasize on this particular segment that we have the pharmacovigilance department. A good number of you are very familiar with Dr. Jayesh, who heads this particular department. Just to journey with you, should you have any concerns, you say your patient has bled, Jayesh is there to journey with you. What happened? How was the drug being taken? Was it a genuine Xarelto pack or it was from somewhere? Unfortunately, some of you are well aware when there are those briefcase drugs that are circulating in our market across all indications, across all products, and you still willingly stock them, yet you know that they are not very genuine, but sometimes the focus on the cash overrides the patient safety. So I actually beseech you, as you're stocking up your different pharmacies, as you're taking part in the procurement processes, think about your family member, think about yourself, think about your child or your children, think about your parents, your grandparents. Are the drugs you're stocking things that chemicals that you would want taken by any of your family members, or they're not genuine, and so you say bahati mbaya to the kawaida mananchi, but I'm looking at my bottom line profits at the end of the day. So just have, I think that's a parting shot I want to leave, because it's a major concern to those of us in the pharmaceutical industry, and I'm hoping that some of these systems might change. But if you have any medical queries and requests for clinical trials, then we have the medical affairs department, and the contacts are as highlighted. And so we say that where we offer protection that never rests. With Xarelto and all our product portfolio across the ranges, we never stop protecting your patients, and we are here to support you and your patients in their journey to good health. And with that, it marks the end of my presentation, and I'll hand the meeting back to you, Bao. Thank you.
Thank you very much, Velma. Thank you so very much for taking your time. And first and foremost, thank you for sponsoring our webinar today. So without further much ado, allow me to go directly to the question and answer session. So the first question is by Dr. Alphonse Manje. Comment, this is to Dr. Susan Mageto. Comment on the reversal of alteplase in PE.
Thank you for that question. When it comes to alteplase, I believe this will be usually in a setting, in a hospital setup, and the reversal is usually very strict. There has to be some guidelines that are ticked before you actually decide to do a reversal. But most of the time, you'll use either, you'll do a blood transfusion, you also maybe do platelet transfusions, cryoprecipitate sometimes, but the most important thing is there's a guideline. I wish I would be able to share. Let me share that. Let me pull it out. I can share in the chat, in the question and answer there. There's a guideline by the American Heart Association, which usually most of these hospitals will use when it comes to the reversal of altiplase. So kindly go through it. I've sent it there. So there has to be some indication for reversal. It's not usually just reverse. There has to be a reason why you're reversing it, and it's not always, because before you decide to give altiplase, you actually need to have done something. You have to have looked at certain conditions before you give altiplase. So when it comes to reversal, something must have happened for you to decide, now we need to reverse this immediately, and there's a guideline there. Okay.
Asante Daktari, asante so very much on that. I have seen it. So the other one, how much is INR POC machine, and how much does it cost?
I think it depends with a brand. Yeah, for those who are starting out, you can do a cheaper option. You can go to Amazon. There usually you can buy a second-hand machine at around $300, $400, $500 there. But you can get a new one, I think, from Sunscope. There's a company in town called Sunscope, and they sell the machine at around 160, 170,000.
Asante. From Dr. Frederick Stenji, the hospital pharmacist in Kajiado, what is the approximate cost of setting up the clinic, and how were you able to attract and retain clients?
Honestly, mine happened serendipity. Yeah, is it serendipity? Serendipity. Serendipity. It was serendipity. Yeah, like I wouldn't say I incurred a lot. I happened to have a mentor who had an office in Fortis Suits, and he gave me space. Yeah, so I was lucky. So I did not, but I think I did not incur quite a bit. But I think if you really want to start a clinic, you need to factor in where you're going to put it. So the rent, the machine, the strips are the ones that are a bit costly, because one strip will go for around 700 shillings. But once your volume of sales increases, then the price will also reduce. Yeah. So, and Wafering, you need to be able to stock your Wafering, but Wafering is very cheap, so that is not usually a problem. So those are the things you need. Not it's you. If I'm positive that if you have around 300,000, you can start something.
Asante so very much on that. So a comment from Dr. Anne Kamau, she says, good presentation, please share. So a point to note is that this recording shall be shared on our YouTube page, and all presentations for this whole year will be uploaded on our PSK website. We are going to be sharing that link soon. From Josephat Misango, when does one decide on giving heparin or low molecular weight heparin?
So it depends. If you have those two, as we said, heparin is not really excreted renally, but warfarin, low molecular weight heparin, that is Clexane, is excreted renally. So if you have a patient who has renal issues, then Clexane would not be your best fit. Another thing is that heparin, you might have a patient who's already has thrombocytopenia, and you know that heparin might cause heparin-induced thrombocytopenia. So you wouldn't go for that. Yeah, you would rather go for the Clexane rather than the heparin. Also, as I noted in my presentation, that heparin has a higher risk of bleeding when compared to low molecular weight heparin. So when you're dealing with those two, and this patient has a higher risk of bleeding, then you'd rather go for low molecular weight heparin. Thank you.
Thank you so very much on the response. So from Douglas Mutzwanzo, for how long should patients on Xarelto, Clopilate, and Pradaxa stop prior procedure like other procedure? For how long should they first stop that?
So it depends. If a patient is on any type of DOAC, if there's a score that we call the Hasbled score that we usually use to score patients and see if they have a higher risk of bleeding or a low risk of bleeding. So if they have a high risk of bleeding, then you can stop 2 days before the surgery and then start 2 days after. But if they have a lower risk of bleeding, then you can start 24 hours before and initiate 24 hours after.
Wonderful, wonderful. So from Evans Nyakeuri, how about weight in choice of DOAC's therapy limited to Xarelto? You can answer probably. Velma can assist you.
Or Velma can assist me. Okay. Basically, okay.
Well, in terms of weight and giving Xarelto, they say do not adjust the dosing regardless of the weight of the patient. So that's the clear what is this? Clear highlight on even the patient information material in every pack. So maybe that's how you can want to talk about the other options of drug.
So the thing is, there's a lot of study going on. That's why even in my presentation I just wrote it's like it's unsure. People are not sure on when to use drugs, especially when you're talking about patients who are obese, especially morbidly obese. So basically, studies have been done, and the one that has actually shown a lot of variability is dabigatran. Dabigatran is reduced to almost, I think, 21% if you give it to an obese patient. The action is reduced to almost 21%. But most of the time, the patients are usually faced with either you give them Wafering or you give them rivaroxaban. And also studies have been shown, some studies have been shown, and the rivaroxaban seems to be doing well. You can actually give rivaroxaban. You can actually give rivaroxaban, but monitor the patient to be able to see if they're actually responding well to your medication.
Wonderful.
So it's in a patient-to-patient basis. Yes.
Asante. So we're going to Emily Mohia's question. Where are the patients seen at the AC referred from?
So this is where collaborative practice is very important. When you run an anticoagulation clinic as a pharmacist, you need to be able to make friends with your counterparts in the medical field. Basically, have, as we said, an anticoagulation champion who is either most of the time it will be a cardiologist or an hemato-oncologist. These are the people who see a lot of patients, large volume of patients who require anticoagulation. And because they've seen the outcomes that you give in terms of patients maintaining their INRs at therapeutic range, and they're happy because they don't have their patients bleeding, they don't have their patients having issues with their knee, they will be sending those patients to you. So you have a symbiotic relationship whereby they send patients to you, and you make sure that once you see them, you write a report and send it to the doctors. That way you keep them updated on their patients, on how their patients they're faring on. The other thing that works, I've seen it working for some people, is you can do what you call aggressive marketing to these doctors. You can hire a marketer just the same way labs hire marketers, and they go and see these doctors and explain to them what you do, and the doctors are able to send patients to you. So you have to be referred. Actually, the best place to start an anticoagulation clinic is usually the hospital, because you have a large pool of patients, and it's easier for the hospital to actually give you all those patients to be able to see. Yes.
Asante sana. Is an independent community pharmacist allowed to prescribe anticoagulants without a prescription, or do they collaborate with a physician who then refers the patients to the pharmacist run the anticoagulation clinic? That is from Emily Moheto.
As a pharmacist or as a clinical pharmacist, I think when it comes to anticoagulation, your major role should actually be the management, the anticoagulation management. So leave the doctor to actually find out what is happening to this patient. And once they find out that this patient has either a clot, and then now you can initiate, you can now start the medication process with this patient. I would think that would be ideal. So referral from physicians.
Wonderful. What approach is accorded in management of hypersensitivity reactions due to UFH injection?
Hypersensitivity reactions to unfractionated heparin.
Yes.
You just follow the normal procedures when you're dealing with hypersensitivity reactions. So what a hypersensitivity reaction is this patient facing? As I said, they can have skin reactions. So what do we do in such cases? You give your what do we call them? Your there's a word that is this there's a word that is inapotea. There's a steroids, yeah, you give your steroid shots. That is the word I was looking for. Yeah, so you give your corticosteroids to these patients. You can also give the normal pyritons to just be, because it's more of an allergic reaction to a drug. So the normal way we deal with allergies is the same way we are dealing with the unfractionated heparin. And of course, you stop it because this patient is having an hypersensitivity reaction. So depending on the severity, you deal with it as an hypersensitivity reaction and you treat it as such.
Thank you. So is there a mobile gadget for INR measurements?
The point of care machine that I was talking about, yes.
Wonderful.
That is the one. So some patients can actually in other settings, especially let's say in the West, people are actually patients themselves are buying INR machines for themselves, and they're able to pre-contest themselves and send the results. So it's the POC machine is mobile.
Asante Daktari. So what is the best advice to patients on anticoagulation therapy with foods, fruits containing vitamin K? Should they avoid them completely or just avoid large amounts? How large is large amounts?
So this is where I want us to get very clearly. If you don't get anything from this session, get this, that when you're talking about anticoagulation and patient education, please don't tell a patient to stop any type of food. It's all about consistency. So if they eat sukuma wiki 5 times a week, just tell them, I want you to maintain eating sukuma wiki 5 times a week. Don't tell them, I want you to stop eating sukuma wiki completely. No. So let them be consistent in their diet. If they're eating cabbage 3 times a week, let them eat cabbage 3 times a week, because you can't it's all about, when it comes to vitamin K and how you view it when it comes to anticoagulation, it's all about consistency. They should be consistently taking a certain amount of vitamin K that they have access to in terms of their diet. So it's consistency when it comes to diet.
Thank you so very much, Dr. Ari, on that good and wonderful response. So as we're winding up, let's probably go to for a patient who was previously on the lateral and is now using Eliquis, but occasionally gets incidents of hematuria. What will be the drug of choice for them?
Pardon?
For a patient who was previously using Xarelto and is now using Eliquis, but occasionally gets incidents of hematuria, what should be the drug of choice for them?
So, I would, as Velma had elaborated, my thoughts would be, first, are we sure that it is the Eliquis that is causing the bleeding? Yeah. So we need to find out, why is this patient bleeding, and if you can attribute the bleeding to Eliquis, then either we reduce the dose of that Eliquis, or we actually change the drug of this patient to something else that we can be able to monitor better, maybe Wafering or something.
Asante. So probably to answer our question on the CPD tokens, yes, previous CPD tokens have been having an issue, but we are working on that. We'll respond soon, and the event shall be on the PPP portal when we are sending, by the time we are sending the tokens. Daktari, take this last question, and as you give us your parting shot, how suitable are combinations of clopidogrel and aspirin?
Those are antiplatelets, and I've seen cases whereby, especially when you're talking about cardiovascular diseases, I've seen places where they use the two. What you need to note is that when you give those two, there's an increased risk of bleeding, so be able to follow up on your patients very well. But they're used concomitantly.
Asante sana. What is your parting shot tonight, Daktari?
I thank you for giving me the opportunity to present to you guys. The other thing is, I hope that we've been able to convince each and every one of you that anticoagulation is a low-hanging fruit for every pharmacist, be it in the private practice or in the public practice, that you should be able to make sure that you have an anticoagulation clinic that is running in your facility. It's very low cost, but it's a place where a pharmacist's impact can be felt very much. So I hope that all of you are able to follow us in this bandwagon of anticoagulation. Thank you. Have a lovely evening.
Asante so very much for the wonderful presentation. So probably before we wind up, we're not yet done with the meeting tonight. Velma Barasa, what is your parting shot?
First of all, I thank you to you and the whole entire PSK fraternity for allowing us to partner with you during this event. Thank you very much, Dr. Mageto, for sharing your knowledge and insights on this whole topic of anticoagulation and just creating a different eye-opener to your fellow pharmacists that they can do much more with the knowledge that they have, especially in the anticoagulation space. And for us, one thing that I'll still emphasize, as you're dispensing, as you're managing your patients, remind them to take the best drug at the right time with the right dosing, with the right frequency, so that they can get the best patient outcomes, and help the patient to understand the why, especially the patients who have a long prescription, the polypharmacy kind of prescription. The more they understand the why they have this long prescription, then the more they will be inclined to being compliant with the medication. So we count on you to journey with us in patient care journey. And yes, we look forward to future interactions. So thank you very much.
Asante so very much. So just before we wind up, I'm joined today by the Dean Mount Kenya University and also a member of the National Executive Committee, Dr. Mungoma. I'll allow him to give his closing remarks.
Bao, thank you so much for this opportunity. I didn't expect to talk, but nevertheless, I think it's important to share. I'm really excited about advanced pharmacy practice. And this is very, very evident from what we have just seen there as a presentation from Dr. Susan Mageto, who is also a colleague of mine. So I'm really, really impressed. And I think even just the depth as well as the quality of the presentation is something that we need to emulate for the young pharmacists. Now, moving forward, I think it's important, again, just to remind our members, PSK, of the upcoming conference that is going to take place at the coast. That is between 1st and 5th of June 2022. And I think this is going to be very, very important because we're going to be getting back again to normalcy. We encourage everyone to participate in this conference. There's going to be quite a lot during this conference. And the advert has already gone out. The call for abstract is there. We have a very short time. So we need to organize ourselves as early as possible so that we don't get to points where we are receiving late abstracts or late requests or people calling to see whether they can still have a chance. We want to maintain that level of quality in terms of how we do things and how we show up. So I think for me, it is just to, again, let's remain consistent. We are getting, this is the second quarter of the year. I know the year is full of a lot of activities, including the general election. However, I think we just need to remain focused. This is also an opportunity, hoping that we also have members of the board, maybe this forum, just to pick up on the issue of recognition of specialist pharmacists, because this is clearly the direction of things. And with recognition of specialist pharmacists, it also means that we improve in terms of what we expect in terms of revenue, in terms of, what we should expect after putting in so many years in education as well as experience in pharmacy practice. So back to you, Mbao.
Santi, thank you so very much, Dr. Thank you very much, our esteemed attendees, for joining us today. So probably just to take you through the call for abstracts, the submission deadline is on the 9th of May. We have roughly 3 weeks that are left for us to be able to submit our abstracts. And this year's theme has been named as the best theme ever by a senior member of the society, saying that our theme is on disruptive advances in pharmacy for improved healthcare. This today is a disruptive advance in pharmacy for improved healthcare. Our sub-themes will be on specialization and advanced practice in pharmacy, leadership and policy, community impact of the pharmacy on health and wellness, innovation and technological transfer to support health products and technologies, and also regulatory harmonization. Other than this, we are also to inform you that the invitation letter will be coming soon. It will be sent and will be shared to your personal emails. You'll be getting it for you to be able to register and join us for that conference. Tumefika tamati wa somo letu la leo. Mimi sina budi ila kuwashukuru wahudhuria wote kwa kujiunga nasi na kuweza kumakinika katika somo letu la leo. Nashukuru kwanza shirika la dawa la Bea kwa kuweza kutufadhili kuweza kufanya hili somo, na pia nitamshukuru mwongozi wetu leo ambaye ni daktari wa dawa Dr. Susan Mageto kwa kuweza kutupa somo letu la leo. Tumefika tamati wa somo letu la leo. Tutapatana Thursday ijayo. Tutaweza kupatana hapo siku ya Thursday ijayo ili tuweze kuwa na somo letu la hiyo siku. Sina mengi ila kuaga. Tumefika tamati, sina mengi ila kuaga. Alamsiki.
Thank you and good night.
Okay, bye.